It's especially fitting that as we mark this 30th year anniversary, we do so by welcoming a lecturer whose leadership helped shape both the field of health promotion and the institutional foundation of this award. It's my distinct pleasure to introduce this year's McGovern Lecturer, Dr. Guy Parcel. Dr. Parcel has played a foundational role in advancing health promotion through his scholarship, mentorship, and academic leadership over several decades. He served as the Dean of the UT Houston School of Public Health, held the M. David Lowe Chair in Public Health, and was the John P. McGovern Professor in Health Promotion, roles through which he helped strengthen and expand the school's national and international reputation, and also shape the next generation of public health education and research. During his tenure at UTHealth Houston, Dr. Parcel held appointments across multiple institutions, reflecting the interdisciplinary nature of his work. He served as professor in the Division of Health Promotion and Behavioral Science here, and he also served as a professor in the UT McGovern Medical School as an adjunct professor. He also served in the Division of Behavioral Science at UT MD Anderson Cancer Center and served as a visiting professor at Maastricht University. Importantly, during his time as the director of the Center for Health Promotion and Prevention Research, Dr. Parcel secured the support that established this John P. McGovern Award Lecture Series in health promotion. Dr. Parcel's leadership at UTHealth Houston was built on a distinguished academic career that began well before his arrival in Houston. Prior to joining UTHealth, he was a faculty member at University of Texas Medical Branch at Galveston. And before moving to Texas, he held positions at the Penn State University and U.S. Military Academy at West Point and Eastern Illinois University. Dr. Parcel has authored more than 200 scientific articles and book chapters and led numerous NIH and CDC-funded research projects addressing topics ranging from adolescent health and chronic disease self-management to smoking prevention and physical activity. His work has had lasting impact, not only through the publications I mentioned, but also through sustained investments in evidence-based programs that continue to be broadly disseminated and are in practice today. Many in this audience are familiar with Dr. Parcel's central role in the development and evolution of intervention mapping, which will be the theme of today's talk. And through this work, he helped translate theory and evidence into a practical framework that has fundamentally shaped how health promotion programs are designed and evaluated and implemented. And the intervention mapping textbook has become a cornerstone in training and practice in our field. Dr. Parcel's contributions have been widely recognized through his career and reflected in the many honors and awards he's received, and you can see those in the pamphlets. The leadership roles he's held and his outstanding scholarly contributions speak to his enduring dedication to advancing the field of health promotion. When I asked Guy this week what he was most proud of in his career, he didn't hesitate. He said, "That's easy, mentoring." And that answer will resonate with many of us. Guy has been an exceptional mentor to generations of students, colleagues, and leaders, someone who not only inspires, but also supports and challenges us to grow and succeed. On a more personal note, which I'll try not to tear up, I want to share that Guy recruited me 30 years ago at a pivotal moment early in my career. He was, at that time, exactly the mentor that I needed. Someone who combined intellectual rigor with generosity, who set high expectations while offering steady guidance, and who modeled what it meant to lead with integrity and purpose. In health promotion and behavioral science, we know how important self-efficacy is. That's the belief in your ability to do something. And it's critical for influencing behavior and ultimately success. And while I'm sure that whatever promise Guy saw in me at the time far exceeded my actual skills and abilities, his gentle reassurance and guidance and belief in me helped me also believe in myself. That support was transformative, and it shaped not only my career, but how I think about mentorship and leadership today. We're deeply honored to welcome Dr. Parcel as our McGovern Lecturer during this 30th year anniversary. Please join me in honoring and welcoming him. Congratulations.
Thank you, Maria, for that wonderful introduction. I'd probably be better off if I stopped now and sat down. It really is an honor to return back to my home. Being in this auditorium feels like I spent a lifetime here. And to be honored with the McGovern Award is on the 30th anniversary is very special. So thank you very much for this opportunity to come back and to make contact with so many friends and colleagues that I've had here. It's been a very special event. Thank you. Now, let's make sure I can make this PowerPoint work. I want to start first by telling you a little bit about how the McGovern Award got set up. And to express, first of all, my appreciation to the McGovern Foundation for funding both the McGovern Award Lectureship as well as the McGovern Health Promotion Professorship. That support has been very meaningful to the Center for Health Promotion. It has enabled the center to do many things that it otherwise wouldn't have been able to do without that support. I met John McGovern when I was a brand new assistant professor at UTMB. I didn't know what I was doing here in Texas, came from Pennsylvania, but I had been active in the American School Health Association and served on a committee with Dr. McGovern to establish a Texas School Health Association. And that was when we first met. Later on, we identified that we had common interests in that Dr. McGovern was a practicing physician who had a huge practice in taking care of children with asthma. And that was one of the first projects that I took on when I started at UTMB. After I moved up to Houston, Dr. McGovern contacted me and said he wanted to know about the Center for Health Promotion and what it was doing. He believed very strongly that one of the ways he could help children with asthma was working with schools. That's where children were at. That's where they had difficulty with asthma. And chronically, they missed a lot of school because their asthma was not well managed. And so he reached out to the schools to try to see how schools could be supportive of children who have asthma to help them maintain attendance and to do whatever the schools could do to help out. When I met with Dr. McGovern, he said, "How can I help out?" And I said, "Well, I can think of a couple things." And we got to discussing back and forth, and that's when he decided to create the lectureship and to create the professorship. And I was honored to hold the professorship for many years. And then eventually that professorship was passed on to Deanna Helsher. And Deanna holds that professorship today and brings much distinction to that professorship. Now I'm going to divide my talk into, well, the program is divided into two areas. What I'd like to do first of all is talk about the people. When Maria asked what would I like to do in my lecture, I thought Well, what's the one thing that I feel most proud of accomplishing during these years? And I decided that really was intervention mapping. And so I decided to focus on that. Um, and then the next part of the program is going to be a panel to talk about the science of intervention mapping. And I'm going to try and talk about the people. Before I get started into that, I'd like you to take a look at the list of the previous awardees of the McGovern Professorship. And note that just go through some of the names and then think back about who are some of the people in the literature who have contributed to health promotion research. And you'll find that over the 30 years, we've been able to bring in leading researchers and practitioners in health promotion. And the value of the professorship has been not only do they come to give a lecture, but they spend time here with the faculty. And in many cases, that resulted in ongoing collaborations, ongoing consultants. So the lectureship has been valued not just in having somebody come in, but the work that is able to continue after they come here. Now, if you take a look at the past recipients, the very first recipient of the McGovern Award was Lawrence Green. And it's appropriate for him to be the first one because he was the founding director of the Center for Health Promotion and Prevention Research. It was called something else when it first started, but evolved into that title. And what Larry did was he recruited a young faculty, many of us were just getting started in our careers, to build a vision of a center that would become the leading place for the science and the development of practice in health promotion. And now that it's been well over 30 years since Larry initiated the center, I think we can all look back and say that his vision has been fulfilled, as the center continues to be one of the leading sources, not just nationally, but internationally, for science and practice in health promotion. Oops. The next recipient of the McGovern Award I'd like to sort of talk about is Hario Koch. And this is the time when I was director of the center and was able to present the award to Hario Koch. I really want to spend a little bit of time talking about him because he is a colleague and friend of the many people in the room today. And he recently passed away. And he was a colleague that we started working with in the collaboration between UT School of Public Health and Maastricht University, and really is the partner, one of our partners in developing health, the intervention mapping framework. And it would not have been possible to do this work without the collaboration of Hario Koch. What we were able to do over time was establish a very close working relationship with the University of Maastricht. And it wasn't just Hario and I who were involved in that. We both brought in colleagues, students, and we had students coming from both directions, to the Netherlands and to the United States. And each year we involved more and more of our faculty and students in the process. One of the biggest strengths I think that Hario brought was not just his scientific knowledge and capability, but also the way he was able to mentor other people and to share his expertise and to bring him along. So I'd just like to, just for a moment, share with you how important this relationship has been, not just to me personally, but many of us here in the room today. I first met Hario back in 1968. Both of us were very young. We had no idea that this would result in a collaborative relationship. But over time, it became a stronger collaboration and involved more and more people, both from Maastricht and from Texas. We shared sabbaticals. Hario came here on a sabbatical and he became a true Texan. He got the big hat and the boots, and he just enjoyed being part of the whole Texas culture. And I enjoyed going to Maastricht. I never learned how to speak Dutch, but became pretty much at home in the Dutch culture. This collaboration, this was the last time that Hario and I were together. And we had an opportunity to sit and talk and look back at what we thought we were able to encourage and to develop over the time. And both of us said the most thing that we were proud of are the people that we mentored and followed sort of in our footsteps to carry on the collaborative work that was taking place between our two groups. I'd like to ask you to pay notice another faculty member who's on the list of McGovern awardees. And this is Kay Bartholomew Eldridge. I know Kay as Bartholomew for so many years, I have to keep remembering that she changed her name when she got married again. Kay passed away several years ago, and this is another example. There would be no intervention mapping if it wasn't for Kay. And there certainly wouldn't be an intervention mapping book if it wasn't for Kay. She was like a dog with a bone. She was going to make sure that this got done, no matter how it would kill everybody else that was trying to work with her. So I'd like to just take a moment about how important Kay was to many of us here today, and how her persistence and work and contribution really was critical to making the whole framework of intervention mapping possible. And I'll say some more about Kay as I go along when I tell the story of how intervention mapping got developed. The theme that I sort of chose for today was planning health promotion programs, the legacy of intervention mapping. Because as I look back, it is a strategic planning process that really evolves over time. It's never been static. It's never been a cookbook. It's always been something that's always growing and expanding and adding new thoughts and new ways of doing things to the process. And I think that has left a legacy of work that I think will and hope will carry on for a long period of time. I'm going to talk about the people who were involved in this legacy, and then I'm going to turn over the science of the intervention mapping more to the next generation of people who are carrying on the intervention mapping program. Now, I know you won't be able to read this slide, so there's a handout for everybody. This is what I'm talking about when I'm talking about intervention mapping. I'm sure many of the students and faculty here are familiar with intervention mapping, but if you haven't been exposed to it before, please take a look at the handout. And basically, this is an attempt to develop a graphic of what intervention mapping is about. And it includes 6 steps for program planning of health promotion programs. And each one of those steps has specific tasks that need to be carried out. Why do we have 6 steps? Well, we started off with 8 steps. And then Hario Koch said, that's too many. Cognitively, people cannot remember 8 steps. But 6 steps they can remember. So it got planned into 6 steps. And over time, the tasks that are involved got more specific, more well-defined, and better developed as we began to grow the program of intervention mapping. But if you want to know what it is, I'm not going to tell you all about these steps and tasks today. So just take a look at this if you want to be reminded about what is intervention mapping. Intervention mapping has resulted in a textbook. There are 4 editions that are available right now, and the 5th edition is hot off the press and will be available any day. And if you're interested in a copy, you can look at the codes on the back page of the handout. The 5th edition, this will be the new one, has new authors and pre-existing authors. But I've read some of the slide presentations that the new authors are making, and a lot has been added and further developed. And it just pleases me so much to see the additional work that is being done. Now I'm going to tell you where I started. I started developing health promotion programs at UTMB in Galveston in 1971. And I was recruited to come to the Department of Pediatrics, the first behavioral scientist that they had in a clinical department. And my job was to teach pediatric residents how to educate patients and how to work with community organizations to advance the health of children in schools. I didn't know really what I was doing. I'd never been in a medical school or on a medical campus before, so this was all new to me. And one of the things the chair of the department made me do was to be a medical student and to go on rounds for a whole month before I was able to do anything else. And so that enabled me to learn about the clinical process. And I tried to figure out how can I teach residents how to be better at educating their patients. When they had 15, 20 minutes of time with the patient, they didn't have the skills about how to involve patients in the learning process. And basically, they just didn't have the tools of what to do. And what became apparent is they needed a tool. They needed a program for how to help their patients learn how to manage asthma. And working with my colleague, Kathy Tiernan, who is here today, we decided they needed a program that could be followed step by step in developing the skills for the management of a chronic disease such as asthma. And Kathy and I created this book called Teaching Myself About Asthma, which could be used in a clinical setting, but we also then worked with the pediatric faculty and residents and how to expand this to school programs so that we could do programs after school with children with asthma to help walk them through how they can engage in managing asthma themselves. The goal was really to keep them out of the clinic and out of the emergency room, and also to enable them to attend school. That was how I began to learn the process of trying to put a program together. I went on then to work on a number of other health promotion projects, both in Galveston, and then eventually I came up to the School of Public Health as a member of the Center for Health Promotion and the faculty at the School of Public Health. And I wanted to just give you kind of a quick picture of the types of projects that I was involved in developing health promotion programs. So I sort of grouped them together. These are the programs that were done with chronic disease management in children. And when I came up to Houston, I was able to partner with Kay Bartholomew, who at the time was a health educator at Children's Hospital. And we began to work on a project to develop the self-management for cystic fibrosis patients. And then later evolved into doing that as well for children with asthma. I also worked in some areas for cancer prevention, primarily around smoking prevention with adolescents in high school and middle school students. And one of the ways in which we began working on the step in intervention mapping for adoption and implementation of programs is we tested out trying different strategies and intervention methods for getting tobacco education programs in the schools throughout Texas. And that led to better understanding of diffusion theory and implementation science and how we could build that into intervention mapping. Then I began working at UTMB in a project with Bruce Simons Morton and with Tom Baranowski. And we started working on exercise and physical activity and nutrition for children, primarily as a way of reducing risk factors for cardiovascular disease. And one of the largest projects that we carried out was the child and adolescent trial for cardiovascular health called CATCH, which has evolved into an international program that is now adopted in schools across Texas, across the United States, and even in many international settings as well. My real love was doing the sex education work. One of my majors when I was doing my doctorate was child development. And I worked with a couple professors who were very involved in childhood sexual development and sex education. And I carried that back with me to UTMB and wanted to develop some programs in sex education. And even started some community programs in which my own children participated in. And they tease me about this to this day. And then when HIV came along, of course, there was a real obvious need for adolescents to be educated for protection and risk reduction for HIV as well as for pregnancy. And I carried out several projects that now have actually grown into multiple projects here in the center addressing sexual behavior and risk reduction for adolescents. Other behaviors that I collaborated with other people, one of the most fun, enjoyable projects was developing positive health behaviors in preschool children. So that took me to working with preschool teachers, which was a whole new world. And then a project that was done at the Center for Reduction of Injury Hazards in daycare homes. And then finally, a youth violence prevention program that I did with Steve Kelder, in which he went out into the community to try and find out whether or not there could be interventions to reduce violence among young people. Now I'm going to move on to talk about relationship and collaboration with Kay Bartholomew and Hario Koch. This is actually this is a picture of Kay at one of her birthdays, and Hario presented her with a logo that was developed for intervention mapping out of colleagues in Maastricht. And Kay, when I started working with Hario, we started talking about the intervention mapping. It became apparent that we needed more input from a behavioral scientist. Kay and I both, Kay did her MPH here at the school and was involved in community health education and then was hired as the health educator at Texas Children's Hospital. And she worked on her doctorate, her EDD in education at University of Houston. So her background was primarily in educational psychology as a way of influencing behavior. And I came out of the old health education programs that were well grounded in cognitive psychology and educational psychology. So we've approached intervention mapping primarily from the point of view of what do people need to learn and what do they need in order to learn using a educational psychology approach. But as we got into it, we realized that that wasn't enough. And I had begun working with Hario and then got Kay involved in working with Hario. Hario is a social psychologist, and Hario then brought to our thinking about intervention mapping in a more theoretical perspective. And he added to it just a really rich background and grounding in social psychology that enabled Kay and I to learn from him and to cooperate social psychology much more into our work. We tried to decide, well, we used the textbook that Larry Green and Marshall Kruder developed called Precede Proceed as a textbook for the course that Kay and I started on health promotion program planning. Larry and Marshall's book was an excellent book, which sort of took an epidemiological approach to understanding what problems needed to be addressed in terms of changing behavior and environmental conditions in order to achieve health outcomes or quality of life outcomes. This book was essential for us in teaching in the course, but when we finished the course, we said, now, can our students walk out of this course, go into a community or a clinical setting or a work site setting or a school setting and develop a health education program? And we said, well, we don't think so. The framework was excellent for analyzing a problem, but the proceed part of precede, proceed did not have enough detail and enough direction for health promotion program practitioners to design and develop a program. So we were working with Hario at the time, and so we asked ourselves, well, how did we do it? How did we go about developing programs? So we sat down and meeting after meeting went through. What did we do? What did we do? How did we involve theory? How did we involve evidence from other research that had been done? And we finally put all these ideas into the first published paper on intervention mapping, which to my surprise gained a lot of attention at the time. And we got pretty good positive feedback. And so Kay came up with the idea, we need to write a book. And I said, have you ever written a book? And she said, no. Well, I have, and I'm not sure I want to do it again. But she was, like I said, a dog with a bone, and said, no, we're going to do this. So then, at this point, I want to introduce Nell Gottlieb. Hario and Kay and I realized that we were not doing a very good job of working in the environmental change as a critical component for health promotion. And we needed someone to help us with that. And we invited Nell to join us. And Nell is a sociologist and had been very involved in doing community organization and community programs in Austin and throughout Texas. And so that was the team that got together to write the first edition of intervention mapping. Once we finished the first edition, we realized, and the editors told us we had to do this, we had to do a second edition. So we started working on that. And before I go on I want to make sure that I express appreciation to Pat Mullen. The time when Kay and I started teaching the program planning course, Pat started a new course in program evaluation. And we relied very heavily on the content of Pat's course and on Pat's input into developing the evaluation step of intervention mapping. And Pat has always been very generous throughout every edition of the book to review and provide very helpful feedback to refining and improving the step of program evaluation. So thank you, Pat. When we knew we had to do the second edition, we said we got to get together and we got to start planning. And at the time, I had a home in New Mexico, which was supposed to be my retirement home. But my daughter changed that plan. But we had many writing sessions where we would start going over draft after draft of the book. And this is one of our writing sessions. Kay Bartholomew's not in this picture. I think she was taking the picture. And you notice Kathy has joined us for this time of brainstorming and trying to figure out what we're going to do, what's going to be new or different in the second edition. So then we came out with the second edition, and it got thicker and a little bit more involved. And I think one of the big steps in the second edition was the refinement of the chapters on theory. And Nell and Hario, Nell spent a lot of time in Maastricht working with Hario to really try to integrate how individual behavior change interacts with being able to make change at the environmental level. Then it came to doing a third edition of the book. And at this point, Maria Fernandez joined us. And at that time, Maria was really doing a lot of work on implementation science, reviewing the literature and really getting excited about how this could expand the adoption and implementation step in intervention mapping. So Maria joined us and really focused a lot on refining and improving and really bringing into some of the emerging theory and practice that was starting in implementation science. Then that was our, this is what, the third edition? This is the third edition? The third edition. We had to add then, let me go back. We then had, for the fourth edition, we added Chris Markham. Chris was one of the first students in our intervention mapping class. And Chris had been involved in many of the research projects that Kay and I were involved in, and just sort of naturally grew up as an intervention mapping person. And then that ended up in the next edition of, oops. The next person we had to add to intervention mapping was Rob Reuter. And Rob was one of Hario's students in health promotion. And later on, Hario moved to become dean of the School of Psychology, and he took Rob with him to join that faculty. And this was a beginning of the passing of the torch to the next generation. And Rob worked very closely with Hario on the theory chapters, and eventually has taken on a major role in the theory chapters. That resulted, that was the fourth edition, and now this is a picture of the authors of the fourth edition. Unfortunately, Kay is not in this picture. She passed away before the fourth edition of the book came out. And I want to also thank Chris Markham, who was there supporting Kay. Kay was actually going through chemotherapy while reading book chapters, right to his last chance to contribute to the book. And Krista was there every day, working with her to help her get through this period of time. Now, Nell was not an author on this last chapter because Nell moved on. She became an artist, but she couldn't leave intervention mapping alone. She began to bring intervention mapping into her artwork, or is it artwork into intervention mapping? I'm not sure. But she started a project in one of the housing developments here in Houston, in which she used intervention mapping as a basis for helping the community plan, trying to improve health outcomes in this planned community. And this is a picture of Hario, Nell, and the third person is Gil DeHoor. Gil was one of Hario's students, and this was his introduction to intervention mapping and to working with Nell on these community projects. And Gil became part of our group and part of our writing team and is here today to join us to talk about intervention mapping. The thing that I want to emphasize here is that this whole program was a result of people getting together, working together, having a commitment to producing something that would advance the field, being free to share with each other, not worrying about who gets the credit, and then working with other students and other faculty as they came along. We developed workshops that took place here in the United States, workshops that took place in the Netherlands, and began to involve more and more people in applying the intervention mapping program, and then also giving us feedback on how they were doing so that we could make programs. At this point, I'd like to ask Nell to come up and say a few words about her experience with intervention mapping, as well as to say a few words about Hario Cope. They developed an extremely close relationship in working on the theory chapters of the book. I want to make the point that we didn't all just work on one chapter. We all worked on all of the chapters, but various faculty would take the lead for the chapters. It's all of the chapters have been a very collaborative project. So Nell, please come up and share your experiences.
Oh. So those of y'all from Houston looking at this picture, this is not my project. It is a most famous community and art project by Rick Lowe, and was founded by him and some other people. And I took Hario and Gil there, Rob has been there, to see what can be done when artists take on community work and also do community development with. It had a young mothers program, all kinds of programs that fed into that, as well as financial programs for the residents who lived there. So I'll just leave that up there because that's us, and here we are. So the last time I was in this auditorium was when we did Kay Bartholomew's memorial and her winning of the McGovern Award. And now here we are for Hario's, and those are both dear friends of mine. And I stand here, with them in my heart today. Guy had asked me to talk about intervention mapping from my perspective and how I got involved. It was about 30 years ago that Kay and Guy and Hario invited me to be on the first edition of the book. And that really changed the rest of my career. It moved in a direction that it wasn't going. I was a faculty member at the University of Texas College of Education, kinesiology and health education, which I'm going to talk about in another minute, about how public health was going at that day. And I was doing a research career development award here, and first under Larry Green and then under Guy. And, the rest is, as they say, history. At that time, most of you are much too young to have known this, but health education was in a time of turmoil. And between the public health people, the school health people, the community health people in these colleges. And it was playing out in the professional associations and also in the schools of public health. So schools of public health had been really focused on community development and community change. And we think of Berkeley, we think of Meredith Minkler and Nina Wallerstein. And then growing out of that, or on the other side of that, was behavioral science. And Larry Green is who we see establishing that at Hopkins and then here. And, you say, oh, yeah, that was going on. Well, yeah, that was going on. But at the American Public Health Association, there would be panels where people were doing standoffs between community development and health and behavioral science. And intervention mapping was walking into that. The other thing it was walking into was the Great War between colleges of education, like where I was, and schools of public health. So the schools of public health didn't think that the graduates of the College of Education programs should be allowed to practice health education in public health settings. And this went on, and Guy was part of this movement for the CHES, the Certified Health Education Specialist credential, which lowered, that's what the School of Public Health would say, which brought the playing field to be more equal for graduates of both types of programs, because they could take the test and show that they knew the curriculum objectives that were part of that, the core objectives. And intervention mapping was walking into that. And intervention mapping, I think, brought all of that together. I mean, Guy and Kay brought the educational focus, both in educational psychology, but also in curriculum development. So I don't think there was any other book that addressed both the public health and the curricular side of it. And intervention mapping does that. They brought me in because I was a sociologist who hadn't been trained in a school of public health. So they thought, she's going to bridge the gap between the public health and behavioral sciences. And I had a master's in psychology too. So that's what I went in to do. And Hario and I worked together tirelessly, fearlessly for years on working on the theory chapters and trying to figure out how we could bring theory at the organizational, community, and societal levels to bear when we're talking about environmental agents. I mean, people who are into intervention mapping know environmental agents, they're people. And so they had, what does this person need to know or think to do that behavior? And we were trying to bring that behavioral piece together with systems theory and thinking about how do new things emerge at each level and form the context. And, it was like higher order thinking, and it was exhausting. And we did that. It was actually done over Skype at first for people who are technology oriented there. And reductionism was the concern at every moment, and it's still a tension that I think is in the book today. So in the initial part of the intervention mapping workshops, we were teaching off of Xeroxes of type chapters. And one of the things that came up, and I'll give a shout out for Maastricht, for Herman Schlama of blessed memory, who notedly at one of those said, what the hell is this? If a butterfly is flapping its wings in Asia, some health intervention is being done in the Netherlands. And he was complaining about how far back do you go with environmental agents? So we were like, well, whatever, right? And so that became another sort of technical thing to think about. Where do you stop in terms of looking at matrices? So Hario was the guiding force in doing the next level of things, which was detailed and horrible. It was it was coming up with methods of change and the parameters. And so there were several generations of Hario's students who went through this. And we had to figure out what are the methods. And then Hario was all over the parameters. What do you need to do for them to be used successfully? And so we worked on that. That comes down to a matrix or two in the book, but it's blood, sweat, and tears of a lot of people. And I think that people don't look at that and are aware of how important it is and how to use that table. So after 3.5 decades, Hario and I became fast friends, fast colleagues. We shared life's ups and downs. When you think about what can happen to a person in all those years, what happened to us and the other members of the intervention mapping team. And in an un-Dutch move, Hario bought a house that had a floor that had his office, but it had 2 bedrooms for colleagues. And so I stayed with Hario, it's been probably 10 years, many years, enjoying cheese sandwiches, which we had every night, and Nutella, and had a wonderful time, family, really. And so this summer, I'm going to go back and stay in the empty house, thanks to Gil and Rob. And so I'll be thinking about Hario at that time, too. So the last summer, Hario and I were together for the last time in person at the intervention mapping workshop. And we were like an old couple sitting on the side, pointing out, oh, this and that. And we were expressing our pride at the members of the current generation that was running the program and giving the lectures. And we were telling each other stories of the good old days and having kind of a great time. Hario was a brilliant intellect. He was a dedicated scholar who shaped public policy in the Netherlands. He was a talented administrator, a mentor extraordinaire, and he was also a kind and caring friend who was clear-headed and straightforward, as are the Dutch. He leaves a beautiful legacy at Maastricht. Rob and Gil are representing today, and also in Houston, and I miss him very much.
Thanks to Guy for a compelling presentation, and to Nell for her contributions and tribute. I'm Ross Shegog. I'm a professor here at the School of Public Health and Behavioral Sciences. And it's an honor to serve as the facilitator for the panel of experts, colleagues, and friends as we explore intervention mapping, the applications and the innovations. It is good seeing Guy. I'll try not to tear up, Guy. It's like the prodigal son returning, isn't it, to the homeland. Biblically, we should slaughter the fatted calf in celebration, have the standard bacchanalia. Today, we do probably have some box lunches and public health budget, When Guy was here, he used to get involved a lot in the theatre and step onto the stage in student skits and appear in farewell videos and the like. And I do remember thinking that as an actor, this fellow is not a bad health researcher. And they've given you an award to prove it, guys. So congratulations. Well done. I was a student of Guy's. Enough said. Guy gave me a picture after I graduated, and it's in my office wall, and I see it every day. It depicts a crusty, grey-haired Gandalf dispensing folklore to a group of hobbits at the fireplace. And I thought, this is cool. This will be a reminder of Guy. And now I'm not so sure. Times have changed. Not that anybody is suggesting that the students are hobbits. Okay, so Guy's presentation reminded us that about the origins of IEM, the people, the partnerships, and the values that have shaped the development and influenced this model. For me, and I'm sure for you, this certainly did invoke the words of René Descartes from the Age of Enlightenment, who uttered the immortal statement, "I think, therefore I am." The nod to K. Bartholomew and Hario Koch that we heard from both Guy and Nell is appreciated. Today is also an acknowledgement of their legacy and the seeds they planted. IM as a developmental framework, there's an amalgam, drawing on the collective wisdom and state of the art in needs assessment, psychology, sociology, anthropology, and structural design, pragmatics of asset allocation and implementation, evaluation, dissemination, and on and on. It draws on theoretically and empirically derived concepts and practices so that others may translate science into their communities. And now there is an emerging new edition of the textbook, the latest in the fleet. In Australia, there's a car commercial that showed all the iterations of the brand's vehicles of the past driving successively into a car wash in the desert. And at the far end of the car wash emerges one glorious late model vehicle. This is the amalgam of all that preceded it, the latest edition in the brand line. Their proud slogan was, "The best we've ever done in the best we've ever done." I think that today we'll be exploring just that, and we'll discover why this is apropos to intervention mapping. Today's panel will build on the current foundations to explore how IM continues to evolve and how it is being applied across the world. We'll highlight how it's being used, adapted, and extended in practice, research, and implementation science. We hope to leave you with a clear sense of why intervention mapping remains both relevant and essential as we tackle increasingly complex public health challenges. I'm pleased to introduce our panelists who will each reflect on a different aspect of IM and its impact. You can learn more about the panelists in your 30th anniversary collectible, which don't go home without it. First, we'll hear from Dr. Chris Markham, Professor and Department Chair of the Department of Health Promotion and Behavioral Sciences, who will kick off the panel by introducing the 5th edition of Planning Health Promotion Programs. Next, Dr. Andrew Springer, Associate Professor in Health Promotion and Behavioral Sciences, will discuss the central role of community assessment and engagement in IM. Following that, Dr. Rob Rutter, Professor of Health and Social Psychology at Maastricht University, will focus on theory-driven planning, determinants, and mechanisms of action. We'll then hear from Dr. Fernandez, who will speak about the role of intervention mapping in advancing implementation science. Finally, Dr. Gil ten Hoor, Associate Professor of Applied Psychology at Maastricht University, will look ahead to the future of intervention mapping. Each panelist will offer brief remarks, after which we will move to Q&A in a panel session. I'd like to invite Dr. Chris Markham to the podium.
We may need technical assistance. There we go. Okay. Note to self, never follow Rosh Shigog on a panel. So thanks for us. And before I start, I just want to say my personal thanks to Guy. So he gave me my start at UTHealth back in the early 90s, and it was working with Guy and Kay Bartholomew on multiple projects using intervention mapping that led me into the doctoral program and then into a faculty position. So Guy, I just want to say thank you so much for your guidance and mentorship over all these years. It's been a privilege to work with you and Kay and Hario. Hario gave me the theoretical framework for my first ever lead author publication. So it really goes back. Thank you to you. So I have the pleasure of introducing you to intervention mapping, the 5th edition, and giving you a little glimpse about what is new.
But first, I want to take you back to the late 90s. As Nell said, back then I TA'd for Guy and Kay, and we didn't have a textbook, so we were forever photocopying updated chapters to give to students each semester. Then in 2001, we had the first edition, yay. So it's pretty epic that 25 years later, we are launching the 5th edition. And I just think that speaks to the sustained relevance and legacy of intervention mapping as a planning framework. So what's happened since the 4th edition? Well, quite a lot. In 2019, we had a special issue in the Frontiers in Public Health, and it highlighted intervention mapping across multiple countries and across multiple health domains, and you can see some of those up here. But also, intervention mapping has gone beyond traditional health promotion. We've now seen it applied in social care, in early childhood education, in organizational change beyond the healthcare sector. So its reach is really impressive. We also have had a number of systematic reviews that looked at the application and the effectiveness of intervention mapping. So the first was in 2017, and it looked at the use of intervention mapping to enhance healthcare professional practice. Also in 2017, a review focused on cancer prevention and control. And then in 2019, a review focused on work disability prevention. And if you look very carefully at those last two, you'll see Hario Koch was a key contributor to both those two reviews. So what do we find across these 3 reviews? That intervention mapping can be an effective planning process, in particular if you use it as designed. So this is a quote from the Cancer Review. Culturally relevant interventions developed with intervention mapping were effective to increase cancer screening and reduce social disparities, particularly when they were developed through a participative approach and integrated the environment. Thank you, Nell. But there's a caveat. Stakeholder involvement and the role of the environment were heterogeneously integrated in the interventions. And if you want me to translate that jargon, that means not so much. Most of these studies didn't include community voice, and they didn't include the environment. Which leads us to the 5th edition. It really isn't what's new. It's really a reiterated, more explicit focus on these concepts that were fundamental to intervention mapping from the very start. The importance of community engagement in health promotion planning, and Andrew will speak much more to that. Building equity considerations throughout your planning process. The focus on ecological models and systems thinking, because we know health is complex. So we need multi-level interventions that focus both on behavior and environmental change if we want to have a sustained impact on health. So what's new? To that end, we have a dedicated chapter now on the core processes, and that's thanks to Rick Crutzen, our colleague in the Netherlands. So really detailed, pragmatic guidance on how to use theory, evidence, community input throughout the planning process. We have updated theory chapters, thanks to Rob, and then new examples throughout the book using a lot more clinical and community settings, and then updated references to the latest guidelines and tools and theoretical models. What's new in terms of the steps and tasks? This is really pretty much the same 6-step process from the beginning, but reiterated and improved upon. And in the right-hand side, you see some of the new additions, again, sort of more pragmatic guidance on, in step 1, how do we really engage community in the planning process? In step 2, how do you do the flip? How do you get from the problem to the solution? How do you identify relevant behavioral and environmental outcomes? Step 3, fabulous updated tables of methods and applications, which is probably one of the key assets in the whole textbook. In step 4, thanks to Rick Crutzen, additional guidance on co-creating, pre-testing, and refining your program materials. Step 5, implementation mapping is now introduced front and center, and Maria will say more about that. And then finally, evaluation planning, extended methods for process and effective evaluation, and more guidance on making sure community voice is involved throughout the evaluation planning process. And again, special thanks to Pat Mullen and Melissa Peskin for their leadership on that chapter. We also have a new case study that guides you through the steps and tasks of intervention mapping. It's a multi-level clinic-based study focused on childhood vaccination. So it will guide you through developing at the behavioral level, bilingual materials for parents, at the interpersonal level, a tailored app for healthcare providers, and then at the clinic level, resources to increase vaccination rates. And then finally, in Chapter 11, we have an updated version of IM Adapt, which is a systematic process for adapting existing effective programs for a new population or a new setting. And thanks to Laura Savas for the case study there. If you want to know more and get your copy of the 5th edition, you can join us in Houston in the coming months or virtually. Maria and our colleagues, Serena Rodriguez and Young Kang, will be hosting workshops on implementation mapping in late May, intervention mapping in early June, and then we'll get you the dates for adaptation if you would like to join us there. I also want to give a shout out to the summer course in Maastricht. If any of you want to have a little bit more of an intense and fabulous meeting with intervention mapping, join them the first week in July. You will meet the loveliest people from all around the world. So thanks to Rob and Rick, Gail for being here today. And then in closing, I just want to say thank you to all of the faculty, the students, the staff that worked on the 5th edition. It really does take a village to launch a new edition. And a special thanks to Julia Schenkman and Taylor Levy. I don't know if they're here, but thank you for getting us over the finish line. So thanks, and we hope that you enjoy working with the new edition.
Okay, good afternoon. It's quite an honor to be here with all of you today. And first and foremost, just want to recognize Dr. Parcel again for your personal impact on me, and more on that later, but importantly, incredible impact on the field and the incredible social network you've created of health promotion practitioners and researchers. So for my session, I'm going to speak on intervention mapping step 1, guiding community engagement, assessment, and health promotion planning. I'm going to try to talk a little bit about the pragmatic use and application of intervention mapping and some of the helpful tools and toolkits that intervention mapping provides. Dr. Parcel thought we weren't going to do a class on intervention mapping today, but I'm going to give you a little lecture here on intervention mapping. So we're going to start out, and I'm just going to, as you heard, it's a stepped approach, and our first step is conducting a needs and asset assessment. And with that, we really try to go engage in deep learning about the health topic and the causes of that health problem, both at the individual level and the environmental level. So each step has specific tasks, and step 1 includes establishing a planning group, conducting a needs and asset assessment, describing the context for the intervention, and stating intervention goals. So as a health promotion practitioner myself, first and foremost, one thing I've really appreciated about intervention mapping are all the practical and practice-based planning tools. In step 1, this includes a linkage system concept and partner mapping to inform who should be engaged in the planning process, guiding principles of collaboration, a logic model of the problem, environmental asset assessment framework, importance and changeability prioritization framework, SMART goals, and our beloved intervention mapping core processes. So the intervention mapping core processes are what we all do, I'm sure, as researchers naturally, but put together in this nice little planning kit with a bow on top that we call the IM core processes. And they include question posing and brainstorming, so valuing the local knowledge of our community partners to start out with, reviewing the literature, applying theory, analyzing existing data, and conducting primary data collection. So in the past couple years, I found intervention mapping to be really helpful in guiding various community assessments I've been part of, including the Travis County Physical Activity Landscape Assessment conducted in partnership with the Travis County community and Be Well communities, Acres Homes Child Out of School Time Physical Activity Opportunity Study, a study conducted in partnership with the Acres Homes community and MD Anderson, Houston Haitian Health Assessment, and a shout out here to Roldine Dulce, who's one of our doctoral students. This is a community health assessment in partnership with the Haitian community here in Houston. And happy birthday to Roldine too today. And also a community assessment of roadway safety in partnership with the Montopolis community, which is one of our communities within the Austin area. So I'm going to talk a little bit more about that assessment and illustrate some of the application of the intervention mapping core processes. So as Dr. Markham just mentioned, I think one thing we've recognized in all of us as health promotion practitioners, the importance of community engagement. So we start with establishing a planning group of diverse community partners and stakeholders. In this project, we partner with the City of Austin Transportation Department. We had great leadership with my community leader, Nicole Trevino, as well as Deb Salvo from University of Texas at Austin. And importantly, and a shout out, to our graduate students, Isabel Thomas and Manasa Ramesh. Importantly, we also engaged young adults. And why young adults? Because young adults have been found to have higher risk for roadway fatality and injury. And why Montopolis? Because Montopolis also is identified as a community in Austin with higher roadway fatality and injury as well. So in exploring the core processes, we started out finding existing data to understand better the problem of roadway fatality and crashes in Montopolis. We also engaged, established community inquiry workshops, participatory learning and action workshops, where we recruited young adults to come help us conduct a root cause analysis to understand better what via their lens is causing higher crash and fatality rates for young adults. We also engaged our two cohorts of community co-investigators in conducting photo voice. So photo voice is a method in which you explore a given topic via photos and writing narratives. And we try to focus both on what's causing the problem as well as what are the solutions. So this group's project was aptly titled A Tale of Two Sidewalks, where they explored differences in the built environment in Montopolis compared to other parts of Austin. If that wasn't enough, we also engaged them in exploring further the environment. So we learned a little bit, how intervention mapping allows the planner to explore at an individual level as well as an environmental level. So we engaged our community co-investigators in conducting walkability audits to learn more about both the potential assets within the Montopolis community, as well as multiple needs in terms of sidewalks, lighting, bikeways, shade, et cetera, using a systematic approach via the MAPS instrument. And if that wasn't enough, we also put our co-investigators to work with conducting peer interviews. So we had them each conduct up to 5 interviews with their peers to explore more of those intrapersonal factors among young adults between around the ages of 18 to 28 years. So some of the themes and quotes, I won't read through all this, but again, we explore both the causes as well as the solutions. And that's something I've learned in my community work. Approach communities with the idea that there are thinking people in communities who know their problem and context better than we ever will as outsiders. So, distracted driving. These are our young adults who were interviewed. It's so normal to be on your phone and crave that kind of stimulation. I feel like you just forget sometimes that you're not supposed to do that while you're driving. Another young adult said regarding DUI, the problem is when you stay out all late and then Ubers start getting expensive. Like no one wants to pay $40 for Uber for 2 people. So a lot of times people be like, screw it, I'll just drive back, if they brought a car. Speeding, one of the main contributors to roadway fatality as well. So a lot of men I know tend to speed a lot. Anytime I've been in a car with a young man, they're just like swerving and going really fast. I think that has more to do with toxic masculinity. Seatbelt use. One stat I saw was that up to 40% of fatalities are due to people not wearing the seatbelt. And hey, who knew that people are still not wearing seatbelts? But apparently so, according to our young adults. But then even I feel like some people think it's cool not to wear your seatbelt. I don't think it's cool getting hurt, so I put my seatbelt on. We also explored active commuting, What are those barriers for walking and biking and public transit use? So here, one young adult said, I love riding my bike. Bike lanes aren't too protected. I've gotten hit twice. So another tool, in addition to our intervention mapping core processes, is an environmental asset assessment framework. So we try to not just explore the problem, but what are those assets within a community that we can activate for our intervention. So a framework I've enjoyed working on in the past couple of years, and a shout out to Dr. Sandra Vandenberg, is a settings and environments framework. And this starts with asking, where do we reach our priority population? What are those settings? And then exploring within those settings, what are the environments that we can harness and activate for health promotion? And what are those environmental assets? That includes the policy environment, the information environment, the social, organizational, cultural environment, and the physical environment. And the aim here is, how do we interweave our intervention design into existing settings and environments, and with the idea of creating an interaction of influence across these environments. So with our work, we learned more about what the settings are that where we can reach young adults in the Montopolis community. We also learned about some of those information environmental assets. So the communication channels that they use, social media, et cetera, as well as the importance of developing young adult created messaging around roadway safety. And lastly, another helpful tool for us in this needs assessment is the logic model of the problem, also known as a risk model. Here, we entered our model and the health problem, anchored our model there, and then we go to the right and we ask, what's the impact of roadway injury and fatality on quality of life? We go to the left of the model, we ask, what are those behavioral causes to that health issue, and what are the environmental causes? And lastly, we go to the far left and we explore further, what are the intrapersonal factors? What are those, in this case, low knowledge, low skill, self-efficacy, for example, for safe driving as well. We have about an hour, I'm gonna go through this, okay, all of it, so hold back. And lastly, in good community engaged approach, we share back our findings with our community, because we see opportunity to impact not only what we're doing to design an intervention, but to engage others in the process. So we held 3 community presentations in the Montopolis community. We just presented a shout out to Isabel Thomas, American Academy of Health Behavior, presented in the city of Austin, have an upcoming webinar as well. So I conclude here and just saying, Kurt Lewin, we know is famous for saying, nothing so practical is a good theory. And I'll say, nothing so practical is a good planning framework for designing interventions. Helpful for community engagement and guiding our community engagement, helpful for exploring the individual and environmental factors, and helpful for guiding us in terms of different planning tools and processes as well. So thanks very much, and just acknowledging all the great people who've contributed to this work. Shout out to our young adult co-investigators who are listed here. A personal appreciation for Dr. Harry O'Koch. I remember when he came here years ago and I got to attend a lecture on fear arousal. Reefer madness, no more, right? Fear arousal might not be the most helpful method, but I don't know. Dr. Reuter can tell me more. What are the parameters to use that method? We used it a lot in health promotion in the 1950s. And also just how generous he was when I visited the Netherlands. And like you all said, just really invested in mentorship. Importantly, I just want to end with recognizing Dr. Parcel again. I don't know if Guy remembers that I called him up begging to get in his class because I wasn't a health promotion student and I didn't have the prerequisites. And Dr. Parcel, I think, was a little hesitant, but thanks to that, really shaped my career and my public health journey. So just a personal note and a great mentor to me too. So thank you all for the opportunity to share.
Okay, thank you. First, thank you to Guy and Maria for making it possible for us to come to this great event. I think it's so much deserved recognition of Guy's work. And so I'm very pleased that I can be part of it. I gave the title of my talk, Carrier's Legacy to Intervention Mapping. It's about the use of theory, no surprise, you've heard a lot about it already. Gerrio was my PhD supervisor, and I've listened closely to Guy just when he had this very nice talk. What did you like best? And what's the mentoring? And I fully understand why you were such close friends with each other, because you are both those great mentors, and Harry was my mentor. So we started working together. I was a student in health promotion, and it was a PhD project coming up. And Harry asked me to do that. And the reason why he wanted to study this, and Andrew was already referring to it, I think the main reason for wanting to study the effects of fear-arousing communication was his frustration with it. His frustration that why are these kind of messages, these scary warnings on secret packages, all kind of images, in this case, fetal alcohol syndrome, drinking alcohol while being pregnant, why are people using this? And the why, it was frustration because Gerrio knew that the theory would say this is not working. Theory like protection motivation theory, help belief model, they're very clear. They say if you perceive a threat, if you see some risk, you're motivated to act against that risk or threat, to mitigate it, to reduce it. But only if you see a way of effectively doing that. If you think, I can do that, and if I do that, that will be successful in averting the threat. So the theory was very clear, and still we are using this. So what's happening here? And we started doing research on this, and many years later, I finished in 2000 with Carlton Peters, who also does a lot of work in intervention mapping, colleague at the University of Heerlen, close to Maastricht. We did a meta-analysis, and the data, and also in my studies, is clear. So it's indeed, this theoretical model is confirmed. People are more motivated to act if they perceive a high threat, but only if they think they can do it effectively, what's recommended, and if it's effective. So efficacy should be high. So threat, efficacy, these are what we call determinants of behavior. And this is what brings us to social psychology. Social psychology is the study of everyday human behavior, I would say. And there are many models explaining human behavior, what drives people to act. And I think Martin Fishbein and Isaac Eisen, already a long time ago, started this work. And I think their model still, Fishbein is not among us anymore, but Isaac Eisen still is. But their models, I think, very nicely summarizes this social cognitive way of thinking about human behavior. It's quite simple. We are motivated. If you are motivated to act, you are most likely to act, but only if we have the skills and if the environment is sufficiently facilitating this. There are no all kind of barriers in the environment hindering you from translating your intention into action. The next question then to ask is, okay, what drives our motivation? And in fact, there are three general constructs there, evaluative constructs. One is, if you see the advantages of doing the behavior, and the advantages are more than the disadvantages. The other thing is, we are most likely to do those kind of things other people important to us also do and approve of. And finally, if we think we are capable of doing it. We might have the skills, but we have low self-efficacy of perceived behavior control. That's not very helpful. That should be. And it should be seen it within our capacity and autonomy. These are general evaluative constructs, and they are informed by all kinds of beliefs about outcomes, what other people do, and what makes doing the behavior difficult or easy. So these are the determinants, and these, in fact, are the primary targets of any health education, health promotion intervention we do. We cannot change that behavior directly. We have to do it through the determinants. And that brings us to what we call the logic model of change. So Andrew has been talking about step one, explaining the problem. From step two onwards, we're talking about the solution. What can we do in order to reduce the health problem? And the first task, of course, is to say, okay, what outcomes do we want to see in terms of health, in terms of people's quality of life? So we formulate outcomes, but that those outcomes will only be realized if people do something. So what do they need to do? And what makes them doing that? Not only for the priority population, but also in the environment of people. There are all kinds of decision makings there who can help in facilitating the environment in such a way that in designing the environment in such a way that it facilitates behavior. So the question you asked there is, what do people need to do and what makes them doing it? And that what makes them doing it are these personal determinants. And I think then you come to the major contribution of Gerjo's work in intervention mapping is how can we make people do it? What kind of training do they need? What kind of education do they need? What are the methods we can use to influence those determinants so people will do the recommended actions to reach those health and quality of life outcomes? And then you have a logic model of change. From the methods you use, you try to reach those objectives. If you reach those objectives, you realize those outcomes. And in 2016, and a lot of people here in the room contributed to it, a paper was published in Health Psychology Review, which is a major outlet for us, in which Gerjo and co-authors talked about the taxonomy of behavior change methods. And he was very clear about this taxonomy. This taxonomy is not a coding taxonomy. If it would be a coding taxonomy, it would be used in a different way. It would mean, imagine you want to promote some kind of health behavior. You look at all the interventions that have been done, and you run a nice meta-analysis on it, and you see, okay, if I look at the effective interventions, what methods did they use? That would bring you to the conclusion then that every intervention we do in the future should use those methods. That's a wrong thing. And what Gerjo was very clear about is that methods should match selected determinants. If you want to increase knowledge, you provide information. If you want to change attitude, you do persuasion. If you want to train skills, you do skills training, guided practice, feedback, and goal setting, and that kind of thing. So I think it's something that's unique to intervention mapping, this matching between methods and determinants that you do not see in other frameworks. And there are many frameworks around, but we will talk more about that. So once we have a method like persuasion, skills training, guided practice, how do we bring that to our people that we want to? Oh, sorry. That's my timer. It's already up. And that's about the parameters for effectiveness. That means I have 1 more minute left, but I will make that happen. So how to effectively translate those methods? And there we go back to theory. And let's imagine that we want to improve self-efficacy, people's confidence in doing the behavior. We use role modeling. The theory is very clear. We should select a role model people can identify with. We should select a role model that's struggling with behavior, but successful, not simply successful. People should have, the target population should have the relevant skills. And of course, in the end, there should be some kind of positive reinforcement, clearly described by Albert Bandura in sociocognitive theory. Look at the work of Edwin Locke and Jerry Latham about goal setting theory. Again, there are clear parameters for effectively using goal setting in your interventions. The more difficult you make the goal, the higher people's motivation to reach the goal. But at the point it's not feasible anymore for them, motivation does not simply reduce, it drops to 0. Again, method of change, if you use it wrongly, it will not be effective. Look at the underlying theory to make it effective, and the same for fear-appeal theory. So in the end, we cut all these kind of tables in the book. It's now in chapter 4, 3 and 4. Oh, sorry, chapter 7, I should be clear about this. Methods to change knowledge, methods to change attitudes, methods to increase skills, methods to change communities at the individual level, at the environmental level. And in the end, it looks like this. We have determinants that we match with methods. We use scenario-based risk information, active learning, whatever. We translate those methods into practical applications, looking closely at the theory, at the parameters, and here at the end are some examples. Yep. So, summarizing, theory that we use in intervention mapping is deeply rooted in social psychology, but it's very particularly well suited to intervention mapping. Thank you. Let's see. Yeah.
Okay, so I get to talk about the 5th step in intervention mapping, which is implementation mapping. So we know that an impact of an intervention is dependent not only on its effectiveness or efficacy, but also its reach. And here's an example of the program that Guy had mentioned, the Coordinated Approach to Child Health, that is really a success story. It's been disseminated in more than 10,000 schools and communities in the US and abroad. And it continues to be disseminated even more broadly. But this is really the exception rather than the rule. And in fact, my interest in implementation science, and particularly in this step, was born out of frustration about developing well thought out, well planned interventions that then were not maintained or were not disseminated broadly to have the maximum population health impact. And as you heard, because we have multi-level and complex interventions, they can be hard to not only plan, but then thinking about the implementation is also incredibly complex. So how do we do that? So over the last about 15 years and gaining a lot of momentum in the last 10 years has emerged the science of implementation. And while implementation was talked about by Everett Rogers in the 50s, it emerged as a science more recently. And it's the study of methods to promote the adoption and use and sustainment of evidence-based interventions. I don't know about you, but I was a fan of Back to the Future, and I thought this was really interesting. If Back to the Future, which is about them going back to the early 60s, was made today, we'd be going back to 1995, which is when I came here. So back in 1995, Guy was already writing about diffusion. And he wrote about the diffusion of an effective tobacco prevention program, and colleagues like Steve Kelder and Deanna Holscher also were talking about this. So this really isn't a new concept, and it wasn't a new concept in terms of planning interventions, or as we call them now, implementation strategies to accelerate the adoption and use, but it has evolved over time. In fact, intervention mapping contributes to the field of implementation science in three distinct ways. One is in designing interventions that are more likely to be disseminated in the first place. And you heard about how the engagement approaches that we use make it more likely to be adopted and implemented and sustained. It's also useful in adapting interventions. We know that an intervention isn't going to work or work in the same way in different populations and settings. And to increase impact, we often have to adapt interventions. And so IAM-ADAPT is a way to do that. Intervention mapping, as you heard, was always part of intervention mapping. Implementation mapping was always part of intervention mapping, but it wasn't explicitly known. And I'll talk about how we made that more known outside of the field of health promotion. But that is the third way that intervention mapping contributes to the science of implementation. I'm first going to just briefly mention, Chris already talked about adaptation and using IAM-ADAPT. And I wanted to give a shout out again to Dr. Pat Mullen, who was really instrumental, along with Kay Bartholomew, in the development of IAM-ADAPT, and particularly IAM-ADAPT online. So this is an online tool that can help you take your program and walk through these steps to adapt an intervention. And it's really very different from other adaptation frameworks out there because of a lot of what Rob just talked about, because it actually helps you identify what are the key mechanistic actions within an intervention that we probably don't want to change or change with caution, while still making something more appropriate for a new population and setting. In terms of implementation, though, the design of implementation strategies to accelerate and improve the adoption and implementation of programs and their sustainability is really the focus of my talk. So implementation strategies are methods or techniques to enhance the adoption and use and sustainment of evidence-based interventions. And they can be discrete strategies or multifaceted strategies. And there was a lot of confusion, and continues to be some in the implementation science world, because they made lists of implementation strategies that were out there, but they didn't really have a lot of evidence about what actually works, just what was being done. And there started being questions about, well, how do they work? So as I mentioned, implementation mapping was always part of planning in the intervention mapping steps. it was step 5. But people who were wanting to implement something that maybe was already developed and evidence-based, but didn't really know how, didn't think about using intervention mapping in that way. So in 2019, along with the colleagues here today and including Gilton Hoare, we published the implementation mapping paper, which explicitly described the 5 tasks of planning for implementation. It has really taken off, and I can say that I was also surprised, like you said, you were surprised about the first intervention mapping paper, and this has really, I think, begun to define my career and that of many others that are coming after, in that it filled a gap in the knowledge of, okay, we understand theories and frameworks and implementation. We understand that there are implementation actors, people who are doing the work, but how do you actually put it together? There's also a special topics issue that was co-edited also by Gil and Byron Powell, who is a leader in the area of implementation strategies. And there's continued impact. As you can see, this is from Frontiers in Public Health. There's also some reviews that are being done, and this is only since 2019. And Young Kang is leading in a systematic review of implementation mapping as we speak, and these are just some of the early results. There are 98 articles that have been included. Implementation mapping also has a logic model that describes the mechanisms or mechanistic action of how implementation strategies work. And this also continues to be a major contribution of this work. And we have folks like Tim Walker and Derek Craig and Young Kang, as I mentioned, and others that are really looking at how do we use these implementation mapping logic models, both prospectively and retrospectively, to try to understand the mechanistic actions of implementation strategies. We have a lot of implementation science training available here, a newly launched graduate certificate in dissemination and implementation science, a seminar series, short courses, as you heard Chris talk about, and a workshop in a series in the fall. So I encourage you, if you're interested in this topic, to look into these short courses. Implementation mapping and intervention mapping play a huge role in these. Thank you very much.
All right, so I will be talking about intervention mapping, the present, the future, and the past. Not per se in that order, but I will try to touch upon all of them. So my intervention mapping journey actually started in the 2nd edition, and I can be very honest about it. As soon as I learned about intervention mapping, I hated it. I was so frustrated that intervention mapping or behavior change in itself was so complex and difficult, and I was so annoyed by all the many questions that were asked within intervention mapping, and I was so annoyed by the comprehensiveness of intervention mapping. And luckily for me, my dear friend Gerjo Kok, also one of my great mentors, was there, and he just looked at me like he looked at in this picture. He looked at me and he was thinking all kind of things, and then he paused for a second and said, well, it's probably not so simple. And then he started telling me stories. And with him telling me those stories, I started to become more and more enthusiastic about intervention mapping. I started to understand it better. And that journey for me continued. So in 2012, I was actually introduced to the people behind intervention mapping, and then not the professors, but the people in the natural environment. And my interest continued growing from the 2nd to the 3rd edition, the 3rd to the 4th edition, all the way up till the moment in 2019 that this paper appeared. This is a paper by Alicia O'Kane, and she actually made my subjective annoyance about the comprehensiveness objective. So she actually showed intervention mapping is the most comprehensive approach that currently exists. But now my annoyance about the comprehensiveness made me actually more proud that I could be part of something so great and that is so extremely comprehensive. So we continued working on it, even up till the moment in 2022 that Geir and I decided to go for a little project in which we started looking or reflecting on 40 years of health psychology. And we just made sure to note down all the milestones of health psychology. And our conclusions were that if you wanted to be a good health psychologist, then you have to know intervention mapping. So if you look at the milestones that we also wrote down in this paper, it's all intervention mapping. And yeah, what the authors here already explained in the earlier talks, it all comes back within health psychology as well. I think a great thing is also that from the fourth edition until the 5th edition, there were some great advancements in the field. So we had colleagues helping visualizing how to select the most relevant and changeable determinants by using those cyber plots. We had this colleagues who created those acyclic behavior change diagrams who actually helped with visualizing how our intervention development should look like and make it more understandable and more comprehensible. Of course, we had implementation mapping in the past 10 years that Maria talked just about, and very recently we also made some conceptual advances in how to use knowledge in your intervention development, or how to optimally use knowledge in your intervention development. Of course, I've also been thinking about the future of intervention mapping, and that took quite some brainstorm, so I would just touch upon a few of the things on it. And I think one very important thing in my personal brainstorm was that there are still too many people who were like me 15 years ago, who just say, we have a problem, and if we have a problem, then we just jump to a solution, and then that's it. And of course, by now we know with intervention mapping, it is way more difficult than just jumping from a problem to a solution. There are all kinds of steps within, all kinds of tasks you have to look at. And I think for the future of intervention mapping, some of the things that we can actually work on is that we can work on this linkage quality. We can actually make it more visible, but we can also help people guide from methods to applications to behavior change. What we can also work on is the reporting standards. What you very often see in the literature is that people say, we used intervention mapping, and then you start reading what they actually used and you don't know actually what they did. And if we can actually increase those improve those reporting standards, then we can also make sure that the replicability and the quality and effectiveness of those interventions become better and nicer. We could think about just-in-time context-sensitive adaptations. This is something that especially more and more came up during COVID, where every other week something else changed, and we needed to come up with new interventions. Intervention mapping is very comprehensive. It takes quite a lot of time, and intervention mapping could also help in the future with more just-in-time interventions. And we should think of equity in each and every single step of the intervention mapping approach. And of course, at all times, we have to continue thinking about how to advance behavior change methods, how to advance theory, how to advance adaptation and implementation. Well, this all sounds like a lot. I agree, it is a lot, and this is just the tip of the iceberg, but I think there are 3 things that I can say about this. The first thing is that not only intervention mapping is improving and advancing, but also the fields around us. So we can actually make use of generative AI to actually make this linkage between the different components of intervention mapping more clear. We can make use of causal inference methods to actually make causal inferences out of cross-sectional data. We can use ecological momentary assessment to identify moment-to-moment changes in determinants and behaviors. We can utilize micro-randomized trials to actually manipulate those things, and so on and so further. A second thing, and I'm very grateful for that, is that we are in the nice position that we can continue to make use of the expertise and knowledge of the first generations. And they are very willing to keep giving this guidance. So I'm very grateful for that as well. And I think the third thing for today, and that's also what I want to end with, is that you helped raising a great first generation. There is a great second generation. Earlier this week, I already heard that there's a fourth generation. And it's great to see that you are always at all times sharing your love with the next generations. So I think with that, intervention mapping is in good hands. Thank you.
Testing. So this is the panel portion. We will try and keep on time. I'm going to do some temporal damage control here. I want to just check if there are any questions for the panel straight off the bat. I know we've got chat happening, and if Erica Frost is monitoring the chat, just to see if there are any questions from the virtual blogosphere out there. Okay, if you have questions, just go to the mic, and we'll try and get a couple in, probably just a couple. That was amazing. I think we just understood that this is the tip of the iceberg. I think we probably all earned our certificate today. If you do a little Google on intervention mapping, you'll find that there's over 1,000 citations on this framework, and that's an accomplishment. And I was in an NIH K Award review panel, and intervention mapping kept popping up, and that's a validation. So you've seeded the domestic market. So I thought I'd sort of cast the net a little more broadly. What's going on internationally? Because you alluded to it, and we've got a couple of foreigners here. What's the story with intervention mapping internationally? And I'll just throw that to the panel.
Okay, yeah, I will try. Well, I think especially in Europe, there is this big, I would not say fight between intervention mapping and other models, but I think we won the fight by seeing that Octane paper already. What we also see is that more and more people start using intervention mapping, and also if they started using some of the other frameworks and then they learn about intervention mapping, they immediately say, oh, this is so comprehensive, this is so helpful, and I really want to use this. And I think if you look worldwide on intervention mapping, and this is just off the top of my head, we have some great colleagues in Australia who are actually working day in, day out on equity and intervention mapping. There are some great projects in the Middle East about vaccination in healthcare workers. There are great community projects in South Korea that we're involved in. It's basically all over the world there are great projects, and not only in health intervention, but also in fire prevention or fire safety in older people. It's everywhere.
And there's a training program, I hear, somewhere in Maastricht.
I have heard about that one, yes.
And Nel and Kai, can you tell you all about it? We've been visiting it for more than 25 years. So every year we have a 1 week of intervention mapping workshop. And that also shows the internationality of it, because we get people from all over the world, health professionals, researchers, and we only allow 50 people to participate, to keep it small, but maybe 10 are from the Netherlands, but the rest are from everywhere. Yep.
Didn't do what I was told to do. That's a new one. I think one of the things that has made me realize what a tremendous impact that intervention mapping and now implementation mapping has had is that I get invited to talk and others get invited to talk all over the world. And so just in the last couple years, we've visited Africa and India, other places in Asia, Thailand, and of course, Europe and many other places. And it's really interesting to see how the methods apply across cultures and across contexts. And of course, it's not exactly the same way, and you have to think about it. We're doing some really interesting work right now in Mexico. Carla Ungar's here, who's a PI on one of those projects, to really see if the processes and the constructs work the same way. And what we're seeing is that they do, and it's helpful. And also extremely helpful is some of the other innovations in adaptation, like I mentioned before. There's one last thing I just remembered. WHO asked us to put together a training, a booklet about implementation and chronic disease, and that should be coming out very soon. And central to that is also planning and adaptation and implementation coming from intervention mapping.
Thank you, panel. I've got many deep and meaningful questions for you, but yes.
Thank you. This has been such a great presentation and lecture. I really appreciate everybody's insights. I guess the educator in me had a question of, do you know if intervention mapping has been well integrated in other public health programs? Like, are there people out there that have been able to deliver this? I know we do it really well here at UTHealth, but just wondering if you had a pulse on that.
I can just share quickly that had been working with Universidad Javeriana in Colombia since 2015, and they've incorporated intervention mapping now into their Master of Health Psychology program. And I just, in terms of the international delivery, what I find exciting is the opportunity to learn more how we improve the model too, via different perspectives and cultures as well. So, but that is one program I know that's incorporated that are teaching intervention mapping that I'm familiar with.
Yeah, it continues to be taught all over the country, and as you heard in other places in the world, as a foundational framework for planning health promotion interventions. I wanted to give a shout out to Karen Glanz, who I see has joined us online, and we continue to use the book that she led on theory, health behavior theory. And in that book is also intervention mapping is mentioned and described, because it's a way of really putting together those theories to help create lasting change.
Thank you, guys. We have one last important question.
Didn't know about that part, but hey, who did this?
Who is the target audience for the book, for those that might not have heard that?
Yep, well, certainly students, but also anybody who's working in health promotion or in other areas related that wants to do multi-level interventions. So this particular 5th edition, we've tried to make it even more pragmatic. So for clinicians working in clinics in community settings, for CBOs, for NGOs. So really, we hope that it's a useful tool for anybody that's trying to think about behavior or environmental change at any sort of level. And just to, Gil mentioned a moment ago, in COVID, they did rapid intervention mapping. So people often say, oh, that's too complicated and it must take too long and it must take 1 million people. You can do it quick. You can do it fast if you ask the right questions along the way. So it's a framework that is just flexible and fluid. If you ask the right questions, you hopefully will end up with a more impactful program.
Thank you, guys. We're going to wrap, but please harass these people at lunch. They'll be wandering around, easily accessible. And I think we just need to acknowledge an amazing array. I mean, this is so complex that, of course, you can't cover everything in the hour we had. And one last acknowledgement to Dr. Parcel. So thank you so much.
Okay. Don't leave yet. Okay, so thank you. Thank you, Guy. Thank you, panel. and thank you all for being here today. It's time to announce the winners of today's poster competition. As a reminder, we're recognizing excellence across 2 tracks, right? There's the student track and the faculty or staff track. And each track will be presenting both a first place and a second place award. When your name's called, please come forward to receive your certificate. So the first place winners get $500 and the second place winners get $250, but not today, your check's in the mail. Okay, so first place winner, Hugo Sanchez Blas. This is in the student category, and since we're short on time, I'll announce the second winner as well. Rosalinda Medrano Carrillo, second place, student winner. And then for the faculty or staff, first place goes to Carla Unger Saldana. Great job. And the second place goes to Chelsea Knipp. Okay, so great job, poster winners. All right, so congratulations to all of you. It's now my pleasure to introduce Dr. Eric Borwinkle. He's the Dean of the UTHealth School of Public Health. And as Dean, Dr. Borwinkle has provided exceptional leadership in advancing the School of Public Health mission in education, research, and service while strengthening its real impact on population health. Guy had dreamed of and began planning, I heard, a new School of Public Health. And Dr. Borwinkle continued this vision and made it a reality. And we're all really excited to be moving into the new School of Public Health this year. Please join me in welcoming Dr. Borwinkle, offering closing remarks.
I'm going to keep my remarks brief as my tradition. First, you didn't come here to hear a dean talk. Also, we've had a great Dutch Appreciation Day. So, yeah, we're going to do well in the World Cup. So, thank you all for being here for this year's John P. McGovern Award Lecture Series in Health Promotion. It's a special year as we celebrate the 30th anniversary. Today's lecture highlights the many important contributions of Dr. Guy Parcel. The Dean Emeritus of the school, so now you've had to suffer 2 deans in the school, still a faculty member, I believe, in this school, and also a valued friend and colleague of many, many people, some of who are here today. Guy, thank you for a memory catalyzing presentation, for walking us through the history of intervention mapping, and for your generous reflection on your colleagues. You brought to life the collaboration and dedication that define this work and that still guides so much of what we do in public health. I also want to add my appreciation for Nell's comments. You brought to life a founding leader in this field, and I greatly appreciate it. I learned a lot and appreciate you being here. I also want to thank the panelists for their thoughtful and illuminating reflections. Your insights helped underscore the continuing strength and adaptation and relevance of intervention mapping in addressing complex public health challenges. Gil, it's complex for a reason. The panel documents the wisdom of the founding fathers and mothers of intervention mapping and passing the torch to the next generation of leaders. I want to challenge the panelists and others to create a foundational infrastructure, but also a long runway of freedom for the next generation to tackle future problems. The world is changing, and the field has to change with the world. Congratulations to the recipients of today's poster awards. The quality of the work presented, I had a great opportunity to walk through the posters, reflects rigor, creativity, and impact of the scholarship across our community, and we're proud to recognize your achievements, very proud. Special thank you to Dr. Maria Fernandez and her team for organizing today's events. This program thoughtfully honored both the legacy and the future of health promotion. Finally, and maybe most importantly, thank you all for being here and the engagement and the work you do to advance public health every day. The progress we make depends on collective effort, collaboration, innovation, and a shared commitment to improving health and quality of life. As I conclude, because I know I'm standing between you and lunch, I'll continue the conversation with you in rooms 102A and B. We hope you take this opportunity to connect and to harass the colleagues, the speakers, and the guests. Thank you again. Maria, thank you for giving me an opportunity to speak. Appreciate it.
Thank you. Thanks so much, Dean Borwinkle. I just wanted to also thank my team who worked tirelessly to put this all together. And in particular, Amanda English, my right-hand person back there, Marsha Lee, Yvette Canales, and then great job on organizing the posters, Donna Lormand and Lizette Gutierrez. And then the other staff at the Center for Health Promotion and Prevention Research that were here to help support. So thank you so much. Guy was saying, we were talking about yesterday that, you know, what really is important and what really makes you succeed is a team effort. And it does take a village. I really appreciate the team. He also once told me, you put a great team together and then get out of their way. And sometimes I take that advice and sometimes probably not as much as my team would like. But thank you so much for being here. Please join us for lunch. And it's better than a box lunch, I will say, Ross. Join us for lunch and conversations around the posters again. Thanks so much and congratulations, Guy.